Please go ahead.
Good morning to all of you. This morning, I'm going to speak on post-operative care of the Glen and the Fontan patient and how one should optimize management and how, in practical terms, we need to go about it. I'll just cross-check what's wrong because the slides are not moving. I'm not able to move to the second slide. Okay, you all have already heard previously about the principles of the Glen and the Fontan surgery, that in effect it's a functional single ventricle, which is a broad term used to describe a wide variety of structural cardiac abnormalities. Situations basically where a lasting biventricular repair is not technically feasible, even with the use of various prosthetic aids like a conduit. Sorry, I'm having difficulty moving the slides. Now, you all are aware what are the situations where we have a single ventricle situation. You have a morphological single ventricle or a functional single ventricle. Morphological single ventricles include double inlet ventricles, absence of one atrioventricular connection like a hyperplastic RV or an LV, and unbalanced AVSDs or various heterotaxy syndromes. Functional single ventricles include hyperplastic left heart syndrome, pulmonary atresia with intact ventricular septum, biventricular hearts which are treated along a functional single ventricle pathway because a biventricular repair is not feasible. Okay, I'm sorry about that. So we go back to the Journal of Thoracic and Cardiovascular Surgery in 2006. They looked at the broad groups of various substrates which go along the single ventricle pathway. That's the Glen or the Fontan surgery. And in most Western centers, HLHS or hyperplastic left heart syndrome constitute more than 50%. This is quite different to our situation where a single left ventricle, that is the tricuspid atresia, is possibly the commonest substrate which goes down the Fontan pathway. Over the last couple of decades, there's an increasing proportion of surgeries which are being done for congenital heart disease in India, out of which at least 5 to 8% of all surgeries for congenital heart disease constitute surgery for single ventricle. In many units, including our own, about 12% undergo surgery every year for single ventricle situation. What kind of outcomes are we looking at? In the current era, early discharge survival has been steadily improving, so much so that the current survivors are more than 95%. For Glen, 96% survival, and for the Fontan operation, early survival or discharge survival of over 99% has been reported. So what do these children die of? In Glen surgery, early postoperative mortality, the causes are usually due to a rapidly worsening, early onset low cardiac output state. This low cardiac output state is then often refractory to conventional modalities and moderate dose of hemodynamic support. And very often it is compounded by associated arrhythmias, which is usually a tachyarrhythmia. That means these babies tolerate fast heart rates very badly. which gives rise to worsening low cardiac output state. There's a negative cascade of events giving rise to death. And in these situations, ECLS is not really an option because discharge survival in single ventricle infants who are put on ECLS is really less than 25%. In the Fontan operation, the usual cause of early post-operative mortality is huge, rapidly increasing collections with anasarca, with very rapidly worsening early onset low output state, which is refractory to conventional modalities. This is often compounded again by associated arrhythmias, tachycardias, or tachyarrhythmias, which gives rise to Fontan failure, worsening low output state, again a negative cascade of events giving rise to death. In the Fontan situation, they need aggressive evaluation or even a takedown of the Fontan procedure in a time-sensitive manner to avoid death. This is the usual scenario where one undergoes a single ventricle pathway. That's a tricuspid atresia, where it is associated with an underdeveloped right ventricle. And in this sort of situation where there's decreased pulmonary blood flow from the start, these children traditionally go down this pathway of an early systemic to pulmonary artery shunt if the oxygen saturation is less than 75%, conversion to a bidirectional Glen or a BCPS at 6 months to 1 year of age, and ultimately the Fontan circulation at 2 to 4 years of age. In the scenario where there's increased pulmonary blood flow and the patients are scheduled to go down a single ventricle pathway, the first step is an early pulmonary artery banding to try and protect the pulmonary vasculature and reduce the progression of increased pulmonary vascular resistance. There's a conversion to bidirectional Glen at about 6 months to 1 year of age, and the Fontan circulation once again at 2 to 4 years of age. This is a schematic diagram of the Blalock-Taussig shunt, and this is just a quick overview because you've all seen it. And this is the classical shunt. This is the modified shunt, showing again a communication between the systemic circulation and the pulmonary artery circulation to augment pulmonary blood flow. In pulmonary artery banding, a band is placed in a moderately loose fashion across the main pulmonary artery to try and regulate and control the pulmonary blood flow. Today, the focus is going to be on the perioperative management of the Glen operation and the Fontan operation. So as you'll have seen before, this is a schematic diagram of a bidirectional cavopulmonary shunt or the Glen operation, where the circulation from the upper part of the body, that is the superior vena cava, is connected to the pulmonary circuit, and sometimes to augment pulmonary blood flow, a source of accessory pulmonary blood flow may also be placed. And this angiogram actually shows the pathway that a bidirectional Glen takes. The completion of the single ventricle pathway usually takes the form of an extracardiac Fontan in today's world. And in this situation, the systemic venous circulation from the upper part of the body as well as from the lower part of the body are all connected to the pulmonary circuit, so that the entire total body circulation, it bypasses one of the ventricles, in most cases bypasses the right ventricle, in effect being an RV bypass operation. All of you are familiar with the various 10 commandments of the Fontan operation, but in reality today, there are only really effectively 2 commandments which we look closely at, and those are pulmonary vascular resistance and the systemic ventricular ejection fraction, both of which are risk factors for early morbidity as well as early death as well as long-term mortality, which we will come to in a little while. Now, this is again the schematic diagram of the normal biventricular physiology, which will show you the entire systemic circulation, venous return, to the vena cava, to the right ventricle, to the pulmonary circulation, pulmonary vascular resistance regulating in pulmonary veins, back to the left side, to the systemic circulation controlled by the systemic vascular resistance. Now, in the Fontan operation, which is a univentricular pathway, it is very clearly evident that the two things which need good control is the systemic vascular resistance as well as the pulmonary vascular resistance, apart from the preload to ensure adequate filling of the single ventricle so that there is optimal peripheral cardiac output. So in effect, for the Glen and the Fontan operation, the principles of post-operative care encompass a number of factors: ventilation, appropriate hemodynamic support, appropriate fluid therapy, anticoagulation, arrhythmia prevention and control, suitable posture and ambulation, nutritional support. I'll also dwell on discharge medications and follow-up. So what is the goal of the Glen or the Fontan operation? Basically, it is to ensure successful or optimal functioning of these unnatural circuits. Effectively, one needs to ensure that there's good pulmonary blood flow, giving rise to good systemic blood flow and good optimal systemic oxygen delivery. Now, the pulmonary blood flow is really equal to the difference between, and is directed by the difference between the systemic venous pressures and the pulmonary venous pressures. So to ensure good passive forward pulmonary blood flow, because there's no pumping chamber now, the prerequisites for these circulations are an adequate and appropriate preload, a low resistance, unobstructed pulmonary circulation. So effectively, the take-home message is to ensure optimal forward pulmonary blood flow, we need to have low thoracic pressures. So thus, the principles of ventilation are very clear. The goal being to optimize pulmonary blood flow and systemic oxygen delivery. Now, all of this, it's very evident, is achieved by either negative pressure ventilation, reduced PEEP, or in the absence of this, by good spontaneous respiration. So to ensure this, we avoid needless sedation once the child comes back from the operating room. We focus on the goal being early extubation so that spontaneous respiration is restored. In the Fontan operation, very often there is increasing lactate levels on 0 post-operative day, and this is not a contraindication to extubation. Last night, we had a child who underwent the Fontan operation for a dominant right ventricle scenario, and the child had increasing lactate levels. This is not a contraindication to extubation. We went ahead and extubated the child, and these lactate levels gradually improve following extubation because spontaneous respiration improves cardiac output and cuts down and improves the lactic acidosis. At the end of the Fontan operation, usual saturations that one achieves are about 100%. Now, this is to just show you, this is a 4-year-old Fontan. And though we normally prefer spontaneous respiration, this child, following the Fontan surgery, had significant left-sided diaphragm paresis. So in this case, we had to use BiPAP to try and reduce the pulmonary vascular resistance. And this we had to institute even more when the left diaphragm paresis subsequently in the post-operative course got compounded by a left basal atelectasis. So even though the focus and the goal is to try and have spontaneous breathing, the main goal is also to ensure normal or minimal pulmonary vascular resistance. And if the lung needs to be recruited, we may occasionally have to take recourse to BiPAP or CPAP. For the Glen surgery, once again, the goal is increased pulmonary blood flow with optimal systemic oxygen delivery. Now, in the Glen operation, the pulmonary blood flow is entirely from the upper body venous return. So any increase in SVC pressures, pulmonary artery pressures, or airway resistance will adversely impact pulmonary blood flow, cardiac output, and can potentially cause systemic desaturation. So this pulmonary blood flow is once again best achieved by negative pressure ventilation, reduced PEEP, and ultimately by spontaneous respiration. And very evidently, because most of the flow is from the system, from the superior vena cava, this is achieved when the child is nursed in the sitting position. So effectively, the principles of ventilation constitute moment the child returns from the operating room, we tend to move the child into the sitting up position. So the infants are nursed sitting up to ensure good pulmonary blood flow. We avoid needless sedation. There is a lot of work from Aparna Hoskote from Great Ormond Street, which has shown that modest hypercardia in the Glen operation is a good thing. So the target is to try and keep PCO2s at about 45. This induces cerebral vasodilatation and it reduces SVC pressures. So effectively, it optimizes the Glen surgery. Again, the focus is early extubation, and usual saturations after a Glen operation is about 85%. Now, what sort of hemodynamic support should one provide? We need to remember once again that an optimal preload is a prerequisite to both these surgical procedures because they are essentially passive circulations. Thereafter, one should ensure that you have good pulmonary vasodilator therapy and good afterload reduction, because following both these operations, there's often a tendency to increase in systemic venous hypertension and intense vasoconstriction. So it is very important that the afterload is appropriately reduced. If there is a single ventricle dysfunction, some level of inotropy is also required. So in practical terms, how does one plan hemodynamic support? What one does normally is, at the time of separation from pump, if CPB is utilized, they usually separate by using dobutamine for the single ventricular support. And in the Glen operation, nitroglycerine is also commenced as pulmonary vasodilator therapy. For the Fontan operation, good afterload reduction is instituted with nitroprusside therapy. The goal is at all times to try and keep the lungs at functional residual capacity so that PVR, or pulmonary vascular resistance, is adequately reduced. This is again the same 4-year-old Fontan whom we had to take recourse to BiPAP to reduce the pulmonary vascular resistance. This child not only had a left diaphragm paresis, subsequently developed left-sided basal atelectasis, which worsened the pulmonary vascular resistance, and then he went on to develop collections on the left side. It is very important, however difficult it might seem, that these effusions are drained so that, again, lungs are maintained at functional residual capacity to maintain optimum pulmonary vascular resistance. Now, how does one grade up the hemodynamic support? By the usual criteria: clinical criteria, hemodynamic criteria like a central venous pressure or the Glen pressure, the left atrial pressure, serial biochemical parameters. Now, because these are palliative surgeries other than mixed venous, what we look at is the AVO2 difference. There's a lot of data from the Norwood surgery on the usefulness of the AVO2 difference. And if it is more than 30%, it usually indicates poor systemic circulation and poor systemic oxygen delivery. Lactate levels are also important, and together the two of them give you considerable information regarding the level of peripheral cardiac output. Epicardial echoes and serial echoes also tell us about collections, about the single ventricle function, and if there is associated valve regurgitation. If we use all of them together collectively, vasoactive therapy can be instituted and graded up in a rational and timely fashion. So after this, usually our plan is that we add milrinone, and the criteria that we use to add milrinone is if the Glen pressures are consistently elevated in a Fontan, if the central venous pressures are consistently elevated, if the SAVO2 or the AVO2 difference is greater than 30%, especially if it keeps increasing, if lactate levels despite preload optimization is high after extubation, and if it keeps increasing, and if the echo shows impaired single ventricle function or mild residual AV regurgitation. Associated hypocalcemia is aggressively treated, and all of us are aware that hypocalcemia in infants and children not only cause systolic dysfunction but also impair diastolic function. Now, to give you an example, this is a baby who was recently operated for the Glen operation. It's a 9-month-old infant who had a modified BT shunt at 2 months of age for pulmonary atresia, intact ventricular septum. The infant was extubated on 0 post-operative day, clinically appeared stable, was mildly tachycardic, but when we looked at the AVO2 difference, which was originally about 28%, it kept increasing, going up to 45%. So milrinone was added for increased Glen pressures, for increased AVO2 difference, even though the lactate levels were normal, and echo repeat done at this time showed mildly impaired single ventricle function. After which the child got better and the child is now getting ready to go home. So to recall, what is the relevance of a mixed venous oxygen saturation or an AVO2 difference? There's enough published data which has shown that when you have an impaired AVO2 difference or a fall in mixed venous oxygen saturation, it represents a significant fall in cardiac index. So effectively, we are not treating blood pressures in these children. We are treating guesstimates of cardiac index, and our goal is to optimize cardiac index or cardiac output. Now let's move on to fluid therapy. Many of them have a level of post-operative SIADH or syndrome of inappropriate antidiuretic hormone production, and there is a significant level of capillary leak. So what does one do? So because they are post-op cardiacs, our usual rule is to give crystalloids at 1 to 2 ml per kilo per hour. What should one give? Isotonic fluids. Why? Because you need to avoid water intoxication. Should one include dextrose? Certainly, especially in younger infants, because they tend to get hypoglycemic. So what are the principles of fluid therapy? We need to monitor preload and the Glen pressures very closely, and we need to optimize them with colloids. But at the same time, we need to avoid very high central venous pressures because they give rise to edemas and fluid collections. So the goal is this, that our target is point C and not to push up to point D, where you get a lot of edema, anasarca, and fluid collections. Now, moving on to anticoagulant therapy. It is important to avoid clotting of this passive circuit because the circulation is very sluggish. So you need to avoid a reduction in pulmonary blood flow and reduce systemic oxygen delivery. So what does this mean in practical terms? In the immediate post-operative period, in the first couple of hours, once we are sure that there is no bleeding, no surgical bleeder, no active drainage, heparin infusion is commenced, therapeutic heparin infusion, which is titrated for the individual child's needs according to activated clotted time or INR levels. Once oral feeding is clearly established, for the Glen surgery, aspirin is instituted, and for the Fontan operation, acetylene or warfarin, as the case may be. Now, what is the relevance of arrhythmia prevention and control? The principles are that these children are exceedingly sensitive to loss of sinus rhythm. So our goal is to ensure and maintain sinus rhythm with a view to optimizing cardiac output. These children have a real prediction for tachyarrhythmias, occasionally for bradyarrhythmias. The reason for that is the intrinsic morphology in some cases, as well as the need for surgical manipulation in the area of the right atrium. So how does one prevent arrhythmias? By doing appropriate surgery, minimum handling in that area. And in the postoperative and perioperative period, we take great care to avoid electrolyte imbalance. We preemptively check potassium and magnesium levels, and if they are suboptimal, they are optimized. All of them leave the operating room with atrial pacing bias. The advantages in the event of tachycardia, diagnosis by an AVI study is possible to see whether there is a supraventricular arrhythmia, and these pacing bias are also very useful for control of some dangerous or malignant tachyarrhythmias. So in effect, atrial pacing bias are of paramount importance and may be life-saving. Sometimes none of this may work, and one may have to take recourse to pharmacological therapy of arrhythmia control, and this is very often life-saving. What about posture and ambulation? The goal is once again to increase venous return and preload in an essentially passive circulation. So as I said before, for the Glen surgery, the principle is to try and nurse the infant sitting up all through. We usually do it for about 5 to 6 months, and effectively this facilitates the SVC flow into the pulmonary circulation, thus improving cardiac output. After the Fontan operation, from day 0 onwards, passive leg movement is instituted, and when the child is a bit more awake, active leg movement with an aim for early ambulation, even with the chest drains in situ. The goal being to improve venous return, preload, and a further improvement in cardiac output. What about nutrition? The main goal is to keep pace with pleural losses, which sometimes can be very substantial, and to maintain adequate oncotic pressures. So early enteral nutrition is instituted in a controlled fashion. We usually tube feed them or gavage feed them in the early post-operative period. The general fluid intake is restricted to about 60 to 70% of recommended daily allowance, but we try and push in adequate calories in that to ensure a smooth recovery. Whatever fluids are lost from pleural drains or from peritoneal drains are replaced with appropriate amounts of colloids. In the absence of renal injury, high protein intake is provided up to about 4 grams per kilo per day. The main goal is to prevent hypoalbuminemia and maintain oncotic pressures. Now, what are the complications of the Glen operation? Sometimes they tend to desaturate to 60s and excuse me, to 70s, 60s, and even 50s. The two most common causes of desaturation are an elevated pulmonary vascular resistance, which was underassessed, or the presence of unrecognized venous collaterals emptying into the inferior vena cava or the right atrium. So this can be extremely distressing and very often a cause of problem. Sometimes they are also prone to tachyarrhythmias even in the immediate post-operative period. A number of Glens, especially the young infants and the older children, they are extremely irritable, which can sometimes be uncontrollable. And this is due to usually increased cerebral pressures. This is ameliorated considerably if the babies are nursed sitting up from the word go. Occasionally, they need phenobarbital therapy to cut down cerebral irritability. In very young infants, pleural collections and ascites may form, and if they are significant despite aggressive diuretic therapy, they might need drainage to keep the pulmonary vascular resistance at optimal levels. About the Fontan operation, complications described are arrhythmias, which need to be recognized and treated, and once again, more often tachyarrhythmias. Pleural collections are very often a bane. Sometimes profound ascites may also occur. Usually with the current surgical modifications, they are self-limiting, and within about 3 weeks they do subside. They all need drainage, especially if they are not responsive to diuretic therapy. Sometimes Lasix infusion helps in mild to moderate ascites. In occasional cases, hemoptysis and heart failure may occur due to collaterals. And occasionally you may have a frustrating scenario of Fontan failure where there are overwhelming infusions, fluid losses with very, very rapid hemodynamic deterioration. This needs aggressive evaluation in a time-sensitive manner, sometimes even a cardiac catheterization, and one needs to seriously review whether the Fontan needs to be taken down and converted to a BCPS. But for this procedure to be life-saving, this has to be done in a timely manner. Just to show you, these are two children who had significant collaterals which had to be coil embolized. because it's very well shown that MAPCAs and APCAs, if they are left unaddressed, they contribute to postoperative morbidity and even mortality following the Fontan operation. Now, this was an instance of Fontan failure that we encountered, a 15-year-old tricuspid atresia, single ventricle physiology, who underwent an extracardiac Fontan with the main pulmonary artery ligation and a BT shunt takedown. This child had had his shunt done elsewhere some years ago and presented to us very late in a very sick state with severe polycythemia. Initial course was very smooth. The child was extubated on the early first postoperative day because he had substantial bleeding on 0 post-op day. Second post-op day, very rapid deterioration with anasarca, huge pleural drainage with worsening multi-organ function. We drained about 4 to 5 liters per day. An echo done at this stage showed a patent Fontan circuit, pleural collections, but the Fontan circuit was thought to be patent, but the Fontan failure was persistent, refractory, and continued to worsen with worsening multi-organ failure. So what should one do at this stage? What we did was, we had 2 options: to go to the cath lab, and what we did was something different. We took the child back to theatre, and the child was re-explored. And what they found was that the conduit was kinked, which could not be recognized on a routine echo, and there was a big clot inside the conduit, despite heparinization. So the conduit was revised. The child made subsequently a very rapid recovery and went home very smoothly. So this case basically illustrates that one should not just sit it out with a rapidly evolving Fontan failure, but needs to be very aggressive in intervening. The other complications which may occur, but which is rare, but which needs to be recognized and we all need to be aware of, is isolated pericardial effusions, which may sometimes lead to gross tamponade. Unfortunately, this may occur at any time. It may also occur post-discharge, sometimes may recur repeatedly, and what we've observed in our series is it occurs more often with polycythemic Fontans and primary Fontans, and they need effectively a close watch. Now, what are the discharge medications, the principles? Again, the goal is to see that after discharge, that an optimal Glen or a Fontan circulation is maintained. So principles are the same: optimal preload, ensure an unobstructed circuit, good afterload reduction. So appropriate restricted fluid intake, avoid dehydration in the form of vomiting and diarrhea, avoid excessive fluids to avoid pleural effusions, and see that appropriate anticoagulation is maintained in the form of aspirin and acetron, good afterload reduction, enalapril for at least 6 months to 1 year in the Fontan. Sometimes you may not need anything in the Glen operation. Following discharge, we do need to keep a close review for pleural collections. This was a child who was discharged with a crystal clear X-ray like this. We had kept him on a close follow-up. A routine chest X-ray done 6 days later showed a substantial collection which needed drainage. Now, what are the risk factors for morbidity and mortality in the Glen? Age less than 3 months, a dominant right ventricle, heterotaxy syndromes, increased pulmonary vascular resistance, associated TAPVC, associated AV valve regurgitation, and in more recent times, low SVC index flow. All of these have been published. There's increasing interest in the Glen surgery and in the Fontan operation. And in the interest of time, I cannot go through all these papers, but in the last 18 months or so, there has been a lot of data looking at risk factors for Glen as well as Fontan. The focus is now more on morbidity because in the industrialized world, mortality has been reduced to an all-time minimum. For the Fontan operation, again, in most centers, as I said, the mortality is less than 1%. So the risk factors for morbidity are single ventricle dysfunction, which is pre-existing, AV regurgitation, which is residual, increased pulmonary vascular resistance, associated TAPVCs, a dominant right ventricle with heterotaxy syndromes, and more recently, data from Toronto Children's has shown that small MAPCAs and small APCAs also are risk factors for morbidity in the postoperative period. So to conclude, Glen and the Fontan operation both constitute challenging surgeries. Good preemptive care is the mantra for success. Optimum and now, if there are any questions, I'm happy to answer them. The question is, what is the colloid of choice? We usually tend to use fresh frozen plasma. In Western literature, albumin is also recommended, but for cost reasons, we use fresh frozen plasma. If the child has had blood loss, or if he is draining, has a bloody sanguineous drainage from various sites, then we do give blood as well to maintain an optimal crit. The next question is, when should one take down a Fontan operation? One take down whenever one has drainage which is more than what is anticipated, which is not coming down, or if there is rapidly evolving multi-organ failure with unstable hemodynamics, like you saw the child that we saw, the 15-year-old, then we went back to theater with the goal of taking down the Fontan, but when they found that there was a clot in the conduit and that the conduit had kinked on itself, then they just addressed that, following which the child got much better. Usually a Fontan takedown is has to be considered if a Fontan operation has been done under suboptimal conditions. That means there is already significant pre-existing single ventricular dysfunction, there is a suboptimally repaired AV regurgitation, or the pulmonary vascular resistance is high, it has been under-assessed, and one has still gone down the Fontan pathway. So the timing has to be right. One should not push the child so that the child is completely destabilized and needs resuscitation. If we find that the hemodynamics are unstable, one needs an aggressive re-evaluation, which starts from an echo, but very often in a Fontan operation, everything is not clearly evident on an echo, and if the child is still having huge amounts of drainage, one needs to go back to the cath lab and redo a catheterization, A, to look for collaterals, and B, to re-look at the numbers to see if the pulmonary pressures are appropriate or if there's any missed structural residual anatomic defect. Thank you. Thank you, Doctor. Thank you very much.